Recognizing warning signs and strategies associated with mental illness. Incarceration has largely replaced hospitalization for thousands of individuals with serious mental illnesses in the U.S., with state prisons and county jails holding as many as 10 times more of these individuals than state psychiatric hospitals. Because individuals with serious mental illnesses are predisposed to committing minor crimes due to their illnesses, many have ended up being detained in the county jail with limited or no mental health treatment until a state hospital bed becomes available for them. Some have even been jailed in the absence of any criminal charges. Training objectives. At the end of this block of instruction, the participant will be able to achieve the following objectives in accordance with the information presented during the instructional period. 1. Define mental illness and distinguish the categories of mental disorders. 2. List and discuss the general characteristics or terminology used to describe persons with mental illness. 3. Define developmental disabilities and related characteristics and how they impact an officer's style of supervision. 4. Examine techniques available for assisting persons with mental illness or mental conditions. 5. List resources available for assisting persons with mental illness or mental conditions. Reasons. In jails, everyone has to tend to the mentally ill. Officers, medical staff, classification staff, and mental health staff. Mental illness is an illness. It is not like a disease that can be cured. You don't give a mentally ill inmate a shot and suddenly the illness is gone. Mental illness in jail is managed through a combination of medications, safe housing, and staff intervention. And staff intervention, in order to be effective, has to come from awareness and training. What is mental illness? Of note, mental illnesses are disorders of the brain that disrupts a person's thinking, feeling, moods, and ability to relate to others. Just as diabetes is a disorder of the pancreas, mental illness are brain disorders that often result in a diminished capacity for coping with the ordinary demands of life. Categories of mental disorders: neurocognitive disorders and functional disorders. Neurocognitive disorders. When there is physical damage to the brain or central nervous system, the disturbance is organic. This is similar to a computer that has received some mechanical injury to its circuit. Neurocognitive disorders can develop as a result of brain trauma or substance abuse, infections of the brain, and certain diseases such as Alzheimer's. Functional disorders. When the brain shows no sign of damage, but nevertheless appears to work improperly, the problem is called functional. This broad category includes problems with anxiety, depression, personality, and psychosis. This group includes emotional problems that are inherited from one generation to the next, as well as emotional problems due to stress. (2016) U.S. jail inmates. As mentioned previously, mental illnesses can affect persons of any age, race, religion, or income. It is not a result of personal weakness, lack of character, or poor upbringing. In 2016, an estimated 90,000 U.S. jail inmates were pretrial detainees with serious mental illness who had been found incompetent to stand trial.
General characteristics of mental illness. In loss of memory, unexplained loss, a person cannot remember the day, year, where he is, or what he had for breakfast. In confusion, they may be preoccupied with fear or imaginary attacks. Other symptoms include disorientation, decreased attention span, or inability to perform simple tasks. Paranoia. This person has a long-standing distrust and suspiciousness of others and has a tendency to look for hidden motives for non-suspicious behavior. Suspiciousness, watchfulness, believes everything has to do with them. Guardedness. They're out to get me. They're planning to kill me. Erroneous meaning is suddenly attached to innocent comments. As time passes, delusions or persecutions escalate until the individual feels that they are under close surveillance everywhere. Words are taken out of context. Danger cannot always be predicted when dealing with people showing such high degree of questionable suspiciousness. Whether these individuals are faced with real dangers or not, they maintain a constant state of preparedness. Paranoid individuals detest being independent because it's a sign of weakness and inferiority. Also, these individuals are unable to trust anyone. Facial expressions, staring or no eye contact, clenched jaw, flaring nostrils, turning red. Verbal expressions like cursing, talking loudly, threatening, complaining, talking excessively. Their body language, increased muscle tension, clenched fists, excessive or abrupt movements, pacing, folding arms, head held down. Their appearance, unkempt, clothes representative of aggression, i.e. like fatigue, inappropriate anger directed at an inappropriate source. Grandiose ideas. These persons believe they are exalted religious leaders or esteemed people from the past. Their antics, which may be amusing or pathetic, need not be affirmed or denied, but rather the individual should be asked more questions. More information. Mania, meaning rapidly changing ideas, constant talking, exaggerated gaiety, and physical overactivity, usually accompanies grandiose ideas. Delusions. False beliefs held in spite of invalidating evidence. Delusions of persecution. A feeling of being spied on or slandered, or that someone is planning to harm the person. Delusions of reference. The person feels a person of some consequence of stature, i.e. the politician, is mocking him. This person reads a newspaper article and thinks it's reference to him. Delusions of being controlled by an external force, such as aliens. Delusions of grandeur. A belief he is a very important person, such as the President Napoleon. Somatic delusions. The unverified belief that something is drastically wrong with one's body, i.e., something is rotting inside the body. Hallucinations, which are false sensations. For example, command hallucinations are voices heard by psychotics ordering them to commit acts. Auditory usually consists of voices heard which may be familiar and often make insulting remarks. Commands may be obeyed. Tactile, usually electrical, tingling, or burning sensations. Somatic may be a sensation of snakes crawling in the abdomen. Visual may see objects or aliens, often in distortion, usually related to schizophrenia. Loss of contact with reality. This person has trouble distinguishing or identifying smells, sounds, and sights in the real world from those in an imaginary world. Exaggerated physical ailments or depression. This person has complaints that may seem plausible in the early stages of psychosis. Complains of body ailments that are not possible. Remains alert to the fact that a person may consider the ailment so excruciatingly painful or hopelessly incurable that suicide is the only way left to end the suffering. Often complaints of depression. Other indicators are slow body movement, soft and flat voice, poor eye contact, or lack of concentration. Extreme fright or anxiety. This person is easily startled, shows decreased ability to focus on a single subject, but may be hyper alert. Fear is a major emotion for many people with mental illnesses. May be so scared that they speak haltingly, jump at a sudden sound, or freeze in absolute terror. The sight of a uniformed officer may either have a calming effect or cause even greater fear, thus confirming the person's delusion of persecution.
Hard to tell just by looking. Outward appearances can be deceiving. Some people with psychosis are indistinguishable from the masses, especially when dealing with situations completely unrelated to their delusions. Medical conditions that mimic mental illness symptoms. Not all symptoms listed are symptoms of mental illness alone. Some medical illness includes symptoms which mimic mental illness. Diabetes, head injury, alcohol and other drugs, epilepsy, side effects from medication, high blood pressure. Court rulings consistently indicate no underlying distinction between the right to medical care for physical illnesses and its psychological or psychiatric counterpart. Thus, the denial of mental health care is denial of health care. Anxiety versus adjustment disorder. Anxiety, apprehension, dread, or uneasiness similar to fear but based on an unclear threat. Adjustment disorder, a combination of emotional, psychological, and physical disturbances caused by identifiable life stresses. Panic attack, an anxiety disorder which is characterized by severe attacks of panic in which the person is overwhelmed with intense apprehension, dread, or terror, experiences an acute emergency reaction, thinks he might go crazy or die, and experiences fight or flight.
Phobias persistent, inappropriate, irrational fear of a specific object, activity, or situation which produces a desire to avoid it. Fears that persist when there is no real danger. Most phobias result in extreme anxiety. Thus, phobic persons may sweat, shake, or panic when faced with the thing that scares them. While these fears may be irrational, the anxiety and fear is very real to the person. Types of phobia significant to detention officers: agoraphobia, fear of being alone in public places from which escape might be difficult or help not available in case of sudden incapacitation, i.e., crowds, tunnels, or public transportation. Claustrophobia, fear of enclosed places which may be seen by a detention officer during handcuffing, enclosure in a law enforcement vehicle with a shield, or enclosure in a cell.
Obsessive compulsive disorder. It is characterized by an extreme, unavoidable preoccupation with certain thoughts and certain behaviors or actions that are repeated against the person's will, i.e., washing hands, bathing, changing clothes, cleaning floors, or brushing teeth.
Post-traumatic stress disorder, PTSD. Psychological and emotional disturbances following exposure to stresses outside the range of normal experiences. such as hurricane, flood, war. Depression. Problems tend to become cumulative and create a snowball effect. This disturbance interferes with independent living. Problems make them sad, then they worry, lose sleep, then worry about worrying, and then they may have health problems. Then it leads to more worrying. Everyone feels sad or blue occasionally. For most of us, these episodes are brief, don't significantly affect our day-to-day functioning, and are not life-threatening. Persons whose symptoms are better accounted for by normal grief are not considered to have clinical depression. However, some people, such as those with a mental illness like depression, suffer a despair that is very severe, long-lasting, debilitating, and life-threatening. They may have experienced a sense of hopelessness and helplessness. People cannot just snap out of a depression.
Bipolar disorder, also known as manic depressive illness, exhibits symptoms of alternating periods of mania and depression. In some cases, people with this disorder only get high, but are rarely or never depressed.
Thought disorder, or psychotic disorders. The individual's mental function is so disturbed that he is incapable of carrying on his everyday activity. The impairment of mental function has developed to a degree that interferes grossly with insight, ability to meet ordinary demands of life, or adequate contact with reality. Illogical thought processes, incoherent speech, social withdrawal, neglect of family, neglect of occupational obligations, and hallucinations or delusions cause the person to be labeled deviant, and in turn, the behavior of the person appears to be beyond their control. Loss of contact with reality and deviance are usually quite obvious and require alertness and knowledge on the part of the officer when dealing with the person. A psychotic person may manifest an almost infinite combination of the mentioned deviant type behaviors. An individual may suffer a psychotic episode for days, weeks, or even months at a time, but the episode would eventually end. It is also possible that one may suffer from one isolated episode and never experience another episode. Acute psychotic episodes are behavioral reactions to extreme and often identifiable situational stress. The episodes may include intense anxiety, extreme mood fluctuations, cognitive confusion, disorientation, incoherent speech, withdrawal, hallucinations, and disorientation. Though persons suffer minor psychotic symptoms, they function reasonably well most of the time. They may be referred to as weird or eccentric, but they are capable of maintaining a level of behavior that does not interfere with their own or others' routines. Under stress, however, they may have more severe psychotic episodes of short duration. The length of psychotic cycles varies with each person.
Excited delirium. The term excited delirium, also known as agitated delirium, is a medical condition that detention officers need to become familiar with. In custody deaths that have been attributed to agitated delirium occurred in North Carolina during 2003 and 2004. The common denominators in these deaths are mental illness, alcohol or drugs in the person's system, and not taking their prescribed psychotropic medications. Usually, the person has struggled with law enforcement immediately prior to their death. Coincidence or unforeseen circumstances? Whatever the answer might be, detention officers should familiarize themselves with what can happen. Excited delirium, sometimes referred to as agitated delirium, AD, is characterized by an acute onset of bizarre and violent behavior and may be accompanied by combativeness, hyperactivity, unexpected superhuman strength, paranoid delusions, incoherent shouting, hallucinations, and hyperthermia.
Personality disorders. Behavior involving antisocial tendencies is of great importance to the law enforcement officer. Studies indicate that although these persons with disorders comprise 35 to 40% of the criminal population, they are responsible for 80 to 90% of all crimes. Of all the individuals with disorders with whom a detention officer might have contact, none are as capable of murder with a smile as is this individual, murder of a citizen as well as of a detention officer. Personality disorders are characterized by deeply ingrained maladaptive patterns of behavior which are, in essence, abnormal. The theories for why they occur are difficult, complex, and in general, not agreed to by psychiatrists, psychologists, and physicians. Most authorities agree that most personality disorders become apparent to the trained eye during the first 3 to 30 months of one's life, and to the average person between the ages of 3 and 8 years of age. A. Biological, i.e., inherited, genetic mutation, glandular, chemical imbalance, autonomic nervous system malfunction, minimal brain dysfunction, etc. B. Psychological, i.e., overexposure to a crippling amount of emotions, anxieties, fears, hostility, or dependency at an early age. C. Cultural factors, i.e., kinds of social influence exposure, cultural shock, cultural conflicts, class conflicts, culture standards for achievement and behavior, and accepted norms or values, and, in general, social or cultural learning. One type of personality disorder that may be encountered in the detention facility is the antisocial personality disorder. It is characterized by a pervasive pattern of disregard for the rights of other people that often manifests as hostility and/or aggression. Deceit and manipulation are also central features. Antisocial personalities, characteristics A. They have a failure to conform to social norms with respect to lawful behaviors as indicated by repeatedly performing acts that are grounds for arrest. B. They are deceitful, as indicated by repeated lying, use of aliases, or conning others for personal profit or pleasure. C. They may be impulsive or fail to plan ahead. Antisocial personalities, characteristics D. They may display irritability and aggressiveness, as indicated by repeated physical fights or assaults. E. They maintain reckless disregard for safety of self or others. F. They display consistent irresponsibility, as indicated by repeated failure to sustain consistent work behavior or honor financial obligations. G. They have a lack of remorse, as indicated by being indifferent to or rationalizing having hurt, mistreated, or stolen from another. Characteristics of intellectual disabilities may be unable to formulate thoughts and answer questions readily. May appear interested in children as they can better understand what children are doing. Often they have poor judgment and little self-confidence. Often unable to foresee the consequences of an act. Characteristics of intellectual disabilities easily influenced by an authority figure. Often inadequate in their personal relationships. Socially immature. Resent unkind nicknames/teasing and may do something foolish because of it. Characteristics of intellectual disabilities. Some individuals with mental retardation are quite sensitive and very aware that they are different. Some individuals with mental retardation, to compensate, may become aggressive in order to feel important. Awareness of being different may be responsible for feelings of inferiority, frustration, and resentment, as a result, less tolerant to stress. Characteristics of intellectual disabilities. Fear may be the major characteristic in confrontation with an officer. Potential for violence or aggression exists in that the appropriate outlet channels may never have been learned by the person with mental retardation. May have speech defects. May have slow responses similar to alcohol or drug abuse. Characteristics of intellectual disabilities are victimized and arrested at a higher rate than the general population. May not have resources to seek help. May be dependent on others for care. May have impaired judgment and communication abilities. Characteristics of intellectual disabilities may have accompanying physical disabilities. Have increased vulnerability, sometimes due to reliance on caregiver who may be abusive. Do not commit crimes at a higher rate than the general population. Autism is a developmental disability that first develops before the age of 3 and seriously impairs development of communication and social skills. People with autism also have a restricted range of behaviors, e.g., frequent repetitive behaviors such as hand flapping or pacing, and interests. Autism is thought to be a spectrum disorder, which may begin on a continuum that may also include Asperger syndrome and pervasive developmental disorder not otherwise specified, two developmental disabilities similar to autism. The degree of impairment in autism can range from mild to severe, and individuals with autism function with varying degrees of independence. Males are 4 times more likely to have autism than females. Characteristics of autism may be nonverbal. Up to 50% of this population may communicate with sign language, picture cards, or gestures. If verbal, they may often repeat what is said to them by others. Characteristics of autism may seem like a poor listener due to lack of eye contact. May have difficulty interpreting body language, such as defensive posture or facial expressions. May have difficulty judging appropriate boundaries of personal space and may stand too close or too far away. May have difficulty seeing things from a different point of view, may have difficulty predicting others' reaction to their behavior. Characteristics of autism are usually very honest, blunt, and not tactful, do not lie well. May not recognize danger of injury, may have limited help-seeking skills, may be unable to distinguish between serious problems, may not know where/how to seek help, may be unable to provide important information or answer questions. May not recognize law enforcement vehicles, badges, or uniforms, or understand what is expected of them when interacting with law enforcement officers, e.g., may be unaware that keeping hands in pockets or reaching into a pocket without explanation will be viewed as threatening.
Traumatic brain injury, or TBI. Traumatic brain injury is an injury to the brain caused by external physical force. Officers may observe or see evidence of the following: problems with impulse control, agitation, frustration, and anger, short-term memory impairments, and problems with processing information, lack of inhibitions, abuse of substances, belligerence, problems following instructions, complaints of headaches and fatigue, difficulty perceiving how their behavior affects others. Important relationships become strained. Individuals with multiple disorders. Individuals with mental illness frequently have additional disorders that co-occur. Two conditions that commonly co-occur with mental illness include substance use disorders and intellectual and other developmental disabilities. Behavioral problems associated with these conditions are compounded and complicated when multiple conditions are present. Compared to individuals with only mental illness, people with co-occurring disorders have more frequent contact with criminal justice system, are sentenced to more time in correctional facilities. They have more difficulty connecting to effective services in the community. They are more likely to be rearrested. They are more at risk for increased suicide, are more likely to drop out of treatment or have less successful treatment outcomes. They are more likely to violate conditions of probation and parole.
Alzheimer's disease is a progressive brain disorder that gradually destroys a person's memory and ability to learn, reason, make judgments, communicate, and carry out daily activities. There is no known cause or cure for Alzheimer's disease. Symptoms of Alzheimer's disease. There is nothing in the physical appearance of a person who has Alzheimer's that will tell you they suffer from the disease. The disease crosses gender and race in who is affected. There are symptoms or behaviors which can be indicative of the presence of Alzheimer's disease, such as confused or disoriented, lost or wandering, agitated, fearful, or angry. Ask the same questions over and over, unable to grasp or remember the present situations, are but a few of the examples. Methods and techniques for assisting someone with a mental illness or mental condition. Don't tell a depressed person to just snap out of it. They can't. Be concerned and supportive with him, not harsh and sarcastic. Be a good listener. Encourage him to participate in activities. Be sure he gets required medication as ordered. Notably, speak calmly and repeat commands. Speaking loudly will not improve understanding. Model calming body language. Examples: slow breathing and keeping hands low. Consider use of sign language and pictures or phrase books if available.
Please review the next 2 slides on your own for more methods and techniques for assisting someone with mental illness or mental conditions.
Delusional statements are unique ways of viewing the world which come in conflict with the views of others. There are 3 possible responses to delusions: agree with them, dispute them, defer the issue. This third option, deferring the issue, in this response, you do not agree with or dispute the person's statement. Rather, you acknowledge the person's view of the world, indicate that it is not your own, and follow with a statement of how you understand the person's feelings. An example of this type of response would be, there are many people who want me dead. There is an organization on TV which had my name on TV. Officer, I can see you're worried about someone harming you. I don't know of anyone who wants to hurt you, but I really would like to assist you in a way I can help make you feel safer.
Supervision. Rules and laws governing the operation, surveillance, and monitoring of jail facilities require the officers shall directly observe at least 4 times per hour an inmate who displays any of the following behaviors: physically hitting or trying to hit an officer, being verbally abusive, stating he will do harm to himself, intoxicated as determined by a score of .15 on a breathalyzer, or displaying slurred speech or smelling of alcohol, or inability to control body movement, displaying erratic behavior such as screaming, crying, laughing uncontrollably, or refusing to talk at all. In addition to display behavior, a previous record of suicide attempt or previous record of mental illness shall warrant observation at least 4 times per hour.
E-LEAP de-escalation model. The E-LEAP de-escalation model provides a framework for verbally de-escalating a person in crisis and getting that person to collaborate with you in getting help. The steps are as follows. E. Engage. L. Listen. E. Emphasize. A. Agree. P. Partner. E. Engage. The goal of this step is to introduce yourself and convey that you are there to help, and to begin seeking information from the person in crisis. L. Listen. Listen to the person's story. The goal of this step is to truly understand the person's concern from their perspective. It is important to understand and to remember that what the person is saying or believing may be real or imagined. Since mental illness is a brain disease, thinking is affected by mental illness. Sometimes their speech can be difficult to follow as well. E. Emphasize. Emphasize what the person is experiencing. The goal of this step is to demonstrate your understanding of the person in crisis and their situation. Empathy is different from sympathy. Being sincere will help convey that you understand the person and what they are going through. A. Agree. Agree on what you have in common. The goal in this step is to avoid arguing about the delusions or hallucinations and to find common ground with the individual in crisis. If you listen well, you can usually find agreement on something. P. Partner. Partner to address the person's need. The goal of this step is to find a resolution and get the person help. Remember to adjust your behavior to that of the person with a mental illness. If the person is confused about what is real, be simple and straightforward. Overstimulated, limit input, don't force discussion. Of note, very emotionally upset, don't take their words personally. Withdrawn, engage in a relevant conversation. Hallucinating or delusional, avoid arguing, respond with feelings. Fearful, be reassuring and calm. Insecure, be caring and accepting.
Pushing buttons. Know what your hot buttons are. What will set you off? We all have them. For example, if a person with mental illness calls you a pig or swears at you, this is not the time to demand respect. Never take anything the person says personally. Remember that most of us have been irrational and said inappropriate things when we're under extreme stress. Recognize your limits. Let another officer take over if you're losing control of yourself. Set a limit with the person using I statement. I really want to help you, but I find it difficult because of your name calling. Or, could you help me and stop cursing so that I can work on helping you? Or maybe, thanks. I would appreciate it if you would try. Sometimes, in order to maintain safety, it is necessary to start with an assertive intervention. Assertive intervention can be used when the person is uncooperative or unresponsive to directives. The person is violating rules which serve to maintain security. The three-step assertive intervention is as follows. Empathy statement. A statement that lets the person know you understand where they are coming from and how they likely feel. The concern statement. A statement that describes to the person that you have concern that needs to be addressed. Action statement. A statement that lets the person know what you want them to do. This statement can be in the form of a request.
Keep in mind, de-escalation techniques are not always a substitute for sound judgment and attention to safety. They are a tool to use when appropriate. De-escalation is not always successful. De-escalating a person in crisis requires time, patience, and practice. Attempting to resolve a crisis too quickly can make a crisis situation worse, resulting in an unnecessary altercation. Be sure to take the time needed when dealing with persons in crisis.
Behavioral health resources. It is a good idea to become familiar with your behavioral health services in your local community, since a large number of those individuals, with whom law enforcement comes into contact, may have a mental illness, substance dependence, or a developmental disability. Local management entity. According to North Carolina General Statute 122C3, 20B, a local management entity or LME means an area authority, county program, or consolidated human services agency. It is a collective term that refers to functional responsibilities rather than governance structure. In addition, North Carolina General Statute 122C3, 20C, Local Management Entity/Managed Care Organization or LME/MCO means a local management entity that is under contract with the department to operate the combined Medicaid waiver program authorized under Section 1915(b) and Section 1915(c) of the Social Security Act. The functional responsibilities of the LMEs include management and oversight of the local mental health, developmental disabilities, and substance abuse service system. They are the local go-to public mental health resource. You can call them to find out about services for persons with special needs in crisis. They coordinate a variety of service providers in their geographical area. Since communities are all different, the service array will also vary throughout North Carolina, based on the needs of the community. LMEs manage the system, they don't provide direct services. In addition to the services available in the local communities, there are state-operated facilities that serve people who have severe and chronic needs that cannot be met in the community. State-operated facilities 1. 3 state psychiatric hospitals, Cherry, Goldsboro, Central Regional, Butner, Broughton, Morganton, 2. 2 juvenile mental health facilities, Whitaker School, Butner, Wright School, Durham, 3. 3 alcohol and drug abuse treatment centers, J.F. Keith, Black Mountain, Blackley, Butner, Walter B. Jones, Greenville, 4. 3 neuromedical treatment centers, Black Mountain, O'Berry, Goldsboro, Longleaf, Wilson, 5. 3 developmental centers, Caswell, Kinston, Riddle Center, Morganton, Murdoch, Butner.
In this block of instruction, we have discussed the importance of being aware of the unique characteristics of mental illnesses and developmental disabilities inmates may have. This block is not meant, by any means, for officers to diagnose individuals with mental illness. The intention of this block is to identify the needs of inmates who may have a mental condition and to assist officers in developing effective de-escalation skills. The duties of the detention officer are going to be multiplied with the increase in the number of inmates with mental illness who continue to find themselves within a detention facility. Until the issue of providing sufficient treatment for everyone who suffers from mental illness is addressed, the detention facility will continue to receive individuals who suffer from these illnesses. There are complicated issues that must be considered for the care and treatment of people with special needs, but they must be dealt with in a humane and consistent manner.